design is the design is simply a comparative course with repeated measures, and the assessment is done at baseline, at 8 months, and also at 18 months. And the outcomes was assessed by both the National Cholesterol Education Program and also the IDF criteria. So the findings usually and CMET's prevalence was increased in case of HIV negative patients, and HIV positive had a lower odds of obesity, hyperglycemia, and hypertension compared to, in fact, the HIV negative population who were on management for other chronic disease. So this dynamics, the biomarker showed significant temporal changes across follow-up, except for systolic blood pressure, highlighting evolving metabolic risk. For example, if we see separately only for HIV positive patient at baseline, 8 months and 18 months, the risk for cardiometabolic measurement is increasing by itself. But when we are comparing with HIV positive, it looks like lower. But the reason for this interpretation is that HIV negative patients who were a comparator for this population were by themselves have this increased risk of cardiometabolic syndrome. Either they may have this hypertension, diabetes, and the like, that by itself is causing a false result when compared to that. So the study has to take the general population as a comparator rather than HIV positive, HIV negative with other comorbidities and the like. So the global evidence, higher incidence of myocardial infarctions, strokes, diabetes in people living HIV are globally reported. And because of this, the WHO and the UNAIDS warn of HIV and non-communicable disease double burden for a recent time. And this problem is significant in sub-Saharan Africa. So the global management strategy updates are there, usually using the WHO 2025 guideline for HIV management and also other publications. It generally summarized that integration of HIV and non-communicable disease has to be considered. So this may optimize ART management, and also WHO strongly recommends integrating diabetes and hypertension care into HIV services, recognizing the overlap between HIV, ART exposure, and cardiometabolic risks. So this also include aggressive management of traditional risk factors like smoking cessations, blood pressure control. We can use for this purpose ACE inhibitors, ARBs, and diuretics and the like. And lipid-lowering agents also should be considered, and also glycemic control by both lifestyle modification and also by using metformin and others. But the problem for this is still is drug interactions with ART should be properly tailored and the like. So lifestyle interventions by far an important thing to prevent cardiometabolic syndrome, and early screening is also vital. So the other maybe global management update on the strategy of improving therapy in HIV patient includes both the use of long-acting oral and injectable therapies, and this has been considered for majority of the population. And the other is also the precision and also personalized medicine also should be considered, and that may also enhance management and also may reduce the risk of cardiovascular incidences. And simplified first-line regimen also should be considered. Currently, the dolutegravir-based regimen remains the global standard. However, especially in Africans, the risk of dyslipidemia and weight gain also increasing in this population. So the cardiometabolic syndrome management is becoming difficult. The other cure-oriented research, especially using gene editing, the other management like immunotherapy or the kick and kill approach and the like may bring future interventions for reducing this problem. Can you hear me?
Yes. I mean, you may want to turn your video
Okay.
off because sometimes that kind of improves the connection.
Okay, shall I off the video? Okay.
Yeah, because there's a bit of a delay,
Okay.
but we can hear you.
Okay. Okay. So the special consideration for low resource, high HIV burden setting, usually screening challenge is one of the things, and usually in developing nations, usually we do have limitation on usually we don't have limited lab setups that have able to detect like lipid, hemoglobin A1C or urine albumin and the like. That is one of the things that should be considered. And the drug access and also interactions also should be properly managed so as to decrease these situations. So ART class and specific drugs associated with cardiometabolic syndromes are high-risk ART drugs like indinavir, lopinavir. These are the PIs with non-nucleoside reverse transcript inhibitors like stavudine, zidovudine, didanosine have been known, and also the moderate risk like efavirenz and atazanavir are also included, and emerging risk like the integrase inhibitors and also are increasing weight gain, especially in Africa, Americas. And the safest options for management may be the use of tenofovir, lamivudine, and imtristabine based management is relatively better for pupils have the high increased risk of cardiometabolic syndrome. But this may not be suitable in case of considering resistance in the like considering resistance in HIV strains and the like. ART class and specific drug associated with cardiometabolic risks. Apart from that, PIs with thymidine analogs like AZT and D40 will increase the highest risk of cardiometabolic syndrome. So we have to, as much as possible, we have to may separate or replace these medications, not to give together. So the efavirenz by itself have a moderate increase in cardiometabolic syndrome with the form of dyslipidemia. Plus, it has also the CNS toxicity that may increase its safety issue. The integrase we have already mentioned, and also drug interactions are the most critical with the PIs and also the integrase inhibitors. So combining PIs with integrase inhibitors also may be the problem. The other thing in recent times, the integrase inhibitors as the backbone of management now as a first line have the increased risk of interactions with food and also drugs, especially with the cation chelation. So that has to be maybe addressed with proper health education so that there should be a separate time for using those medications and increase the outcome of the treatment. The research gap, especially in developing nations, especially sub-Saharan Africa, the long-term effects of newer ART medications not well studied, and also improved risk of prediction tools calibrated for people living with HIV is not yet properly used. Considering the National Cholesterol Reduction Program, the IDF has been preferred on people living with HIV/AIDS, but still we need to have the proper calibrated tool for detecting this risk on the people living with HIV/AIDS. Implementation research on integrated HIV and non-communicable disease care models should be also considered. And the mechanistic studies also require much more studies that may give us the better outcome on management of HIV. So what is important is we need to treat cardiometabolic risk as a written integral part of HIV care. This is one of the things as a takeaways, and also a personalized ART has to be incorporated, because in the earlier mass management with fixed or combined ART medications is not working for all individuals. So individualized based therapy as personalized medicine has to be incorporated as also recommended by the WHO in recent time. So the integrating also like smoking cessation programs and also prevention strategies for BP, diabetes, and the like will improve the risk of cardiometabolic syndrome in this population. So addressing also the CKD, chronic kidney disease, proactively, especially during follow-up by screening the creatinine or protein, urea or glomerular filtration rate and the like may also help us to control and prevent cardiometabolic syndrome in these populations. The other point may be the impact of the US funding cuts on policy shift in Africa and especially in East Africa and Ethiopia. And because dozens of US funded health projects terminated in Africa in recent time, since February 2025, in Ethiopia, the freeze has been described as particularly severe. Ethiopia is considered largely benefited from the USAID program. So because this over 270,000 are at risk because of community programs and also drop in centers for especially for women, use key populations and the like, and also the HIV testing, free HIV testing on different setups, and also the management using also ART and also preventive service such as the PrEP has been paused, and because of this it is creating great problem, especially in Ethiopia. So the freeze also disrupted Ethiopian sales information systems. Especially, I have even tried to communicate with the responsible person on the Woldu Memorial Hospital, especially that is the one that have conducted the study, how the impact is producing effect on patients in Woldu Memorial Hospital as one of the hospital that has introduced ART management for the first time in Ethiopia, and also recently have the largest populations on its catchment area, plus in hospital follow-up and the like. So they told me that still the ART management is being progressed, and there is no interruptions of ART medications. But the problem for data collections and the monitoring parameters for especially considering cardiometabolic syndrome, if there is no proper screening and the like, that will not be reported. So those database systems of reporting and also registering and also some of the additional things like the PrEP and the like is declining. So it may have effect in midterm and also in the future, so we will see. Unless and otherwise, the government of Ethiopia and also in Africa, especially the government has to take some effect to prevent the coming disaster in people living with HIV/AIDS. So in Ethiopia alone, over 5,000 public health workers whose contracts was US funded were impacted. So community-led preventions, outreach to key population, data collection, analysis, and support service have been ineligible for the humanitarian waivers. So the consequence and the risks from medium to long term, risk of service interruptions is possible in the futures. ART supply disruptions will be expected unless and otherwise is funded or covered by the government. I don't think. And HIV testing and also preventions gaps will be the risk factor, and also disrupted outreach to key population, especially on countrysides, and also the coverage on the this area populations who are living on the outreach sites will be largely impacted. So the other thing is the loss of human resource, because thousands of health workers laid off or suspended because of lack of this funding from the US funding. So like data clerks or outreach workers, peer educators, community health staffs are becoming losing their jobs, and this may also have an impact in the now and also in the future. The data disruptions is one of the great impact on HIV monitoring data and also early infant diagnosis, and the viral load testing, health information systems is also will be disrupted. So reversal of the progress, especially prevention campaign, community outreach, support for vulnerable populations will, so if those informations are not disseminated problem, the prevalence of HIV may be feared to be increased in recent time because of this issue. So what will be the proposed solutions? So a short term should be addressing integrated non-communicable disease with HIV management. And the other is task shifting and healthcare work training. We have to train healthcare professionals, and also we need to task shift to deliver both service, non-communicable disease and also HIV together. And the other option may be strengthening other cares like the medication therapy management, therapy drug monitoring, and also pharmaceutical care models in the HIV management system so that it can be addressed. And the other may be sustainable financing system from both domestic and also blended models, if possible, has to be tried to alleviate this problem. The long-term solutions may be scale up domestic resource mobilization for health and also introduce strengthening pooled health financing, innovative financing mechanisms, and also regional pooled procurement and also local manufacturing will be. And the diversify the research and also program funding will be the solution for longer term. So in summary, cardiometabolic syndrome is a growing burden threatening HIV gains, and also people living with HIV shows higher cardiometabolic risk susceptibility, both locally and also with global evidence. So funding cuts jeopardize care for multi-morbid, especially people living with HIV/AIDS with comorbidity, and need integrated care, sustainable funding, and also innovative policies for intervening these funding cuts. So I would like to acknowledge the University of California for this great opportunity for me, and also I would like to thank the DAAD, German Academic Exchange Service, for sponsoring this work of mine during my PhD study. And also I was studied in Muhimbili University of Health Science and Allied Science at Tanzania. I would like to acknowledge MUHAS and also at University, where I'm currently working. Thank you. This is a reference. Thank you very much.
Thank you so much, Dr. Woldu, for that really excellent talk. I know that folks probably have some questions, but before we move to the Q&A component, I'd like to hand it over to Dr. Dersenfeld to kind of lead a discussion around this topic, and then we'll end the Q&A at the end.
Thanks, Dr. Woldu, for sharing your perspective with us today and your expertise. The first, I have a couple of topic areas that I wanted to cover during the discussion part. One is, in the global landscape of cardiometabolic disease and HIV, the REPRIEVE trial is obviously kind of the talk of the town the last few years. Specifically in Africa, there's some studies from Mark Seidner in Uganda and others suggesting that, and even in the REPRIEVE trial itself, that dyslipidemia maybe doesn't lead to the same degree of atherosclerosis as in the Western or North America, Europe, and maybe heart failure is a much bigger burden. So I'm curious your perspectives on how REPRIEVE has changed kind of the prioritization or the kind of clinical practice within Ethiopia.
Okay, thank you very much. I think I've seen that study. It is really an excellent work published on I think New England Journal of Medicine in 2023. And considering that study, I think the study have a great impact for preventing cardiometabolic syndromes in people living with HIV/AIDS. And except that the study is focusing on only atherosclerosis. But in case of cardiometabolic syndromes, we need to address several things like hypertension has to be there, dyslipidemia, or the weight gain, especially central obesity, has to be addressed and the like. But in this case, we are addressing only atherosclerosis. It is, in fact, one of the things that is causing mortality on HIV patients, if it's especially considering the ART medications and the like. So that strategy, and also taking the pitavastatin as 4 milligram daily, maybe with lower drug interactions considered to the other statins, and preventing the risk that is coming to kill individuals with taking ART medications, and also have the infections of HIV will be beneficial. So that study is an excellent type of study that has to be considered as a part of follow-up care, but also we need to address the other problems also.
Yeah, talking a little bit, you specifically mentioned just now about obesity, and there's obviously a growing epidemic of obesity worldwide, and including among people with HIV. I think your study at Zuditu, I'm sorry if I'm not saying that correctly,
Yeah,
suggested
very
that it's you know, in that time period you were looking at, obesity was lower among people without HIV. Can you talk a little bit about the temporal trends in obesity prevalence and whether kind of the shift with the WHO and in Ethiopia towards integrase-strand dolutegravir based regimens as first line, if you've started to see a shift in obesity?
uh, I
We
think
can
that
still
it is
hear you.
interrupting, and so can you maybe repeat it? Maybe I don't know. Maybe the video
Yeah,
is good.
let's talk a little bit about obesity. There's a growing epidemic of obesity worldwide, including in parts of Africa. Can you share a little bit more about your insights from your study, um, and about the kind of temporal trends in obesity and whether you're seeing an increase in obesity with the shift towards dolutegravir-based ART regimens as first line?
Okay, thank you. Really, that is a nice question. When I was collecting data for this study, it was just the phase at the beginning of introducing integrase inhibitors. I think the 1 year data that I've taken was not part of the integrase inhibitors. Then after that, I have seen that for 1 week, additional 1 year, I have seen the maybe slightly. In fact, my objective was not targeting integrase inhibitors initially because I'm generally measuring those parameters, especially fulfilling cardiometabolic syndromes. And later, when integrase inhibitor is incorporated, there is a slight increment in weight for individuals with HIV/AIDS that on follow-up care. And at that times, I was not expecting that the medications is causing those problems because in earlier times, the PI is also there causing similar problems, central obesity. So that was what I have seen as a part of my study, especially during the phase between baseline 8 and 18 months. I have seen that those risks, except systolic blood pressures, the other all parameters were increasing slightly. Among that, the central obesity is one of the parameters. So most probably, integrase inhibitors is causing those problems.
I'm going to
In
interrupt for 1 minute. Dr. Woldu, if you don't mind, you can maybe stop sharing your screen so we can see the participants on the screen, if that's okay.
Okay.
Yeah. All right. Thank you.
Okay. Okay.
do you want to try putting your video back on and we can see if that works for the
Okay.
discussion?
Okay.
The next thing I wanted to ask you specifically mentioned, challenges in diagnosis and kind of the importance of focusing or including kidney disease as we think about cardiometabolic risk. And the American Heart Association has unveiled a kind of shift in frameworks to the cardiometabolic kidney syndrome, specifically highlighting that part of it. Can you talk a little bit about the kind of chronic kidney disease and the access to testing to diagnose, microalbuminuria or kidney dysfunction?
Yes, as I think as one of the criteria among the WHO criteria, it has been included as optional parameters of measuring this kidney function. And usually I was not directly measuring creatinine or other measurement for detecting CKD or acute kidney injury and the like. But based on other studies done, especially medications like tenofovir is known for causing the object study, I was not directly measuring creatinine and the like. So I don't have enough information on this regard. Sorry.
Mhm. Maybe a future study.
Yeah. Because
Uh,
there are also studies specifically done tenofovir with CKD and the like,
mhm,
and slightly out, but I was even considering to include it as a part of my study, considering the optional parameter of the WHO criteria on measuring cardiometabolic syndrome, because at the end of the day, patients with cardiometabolic syndrome also developing CKD.
mhm.
So that has to be also intensified when we do have also medications that may increase the risk like tenofovir and the like.
Um, Shifting gears a little bit, you highlighted, the real human cost of the changes in U.S. funding, both in terms of vulnerable populations and in terms of the healthcare workforce. And I do think it's important that we hear that and recognize those political decisions have major consequences. Um, I appreciated your couple of slides about potential solutions, both short term and longer term. I'd love to hear some more thoughts about kind of this alternate perspective that maybe this is an opportunity either for decolonization or for kind of more integrated care models rather than the kind of donor-driven disease-specific priorities.
Yeah, that, because in earlier time we do have one quote, especially on tourism in Ethiopia. We call the country have a motto of 30 months of sunshine. Because in Ethiopia we do have 13 months and we have also 13 months of sunshine. That comfort zone will make you lazy. And when you see Europeans, they do have this challenge, the ice period, and also the different environmental conditions make them very strong to survive. And similarly, it works here because now the funding is already stopped, especially for majority of the data collections or also follow-up care and the like. So we have to have a different solutions, and that will make decolonizations of the areas and also uh, bringing the good solution for managing those situations. And maybe it is an opportunity, but for the time being, if we are relying on those funding, also we may suffer a lot. So the best thing is to have an optional mechanism to solve those current situations.
Yeah, and I think hearing those stories about the costs also helps us on the US side to be better advocates to try to restore some of that funding or do our part to highlight the importance of those funds and the real difference they can make. I think the last area I wanted to bring up is, you had a slide, I think, about the research gaps, and I was curious about your thoughts about how this current research funding landscape, I think many of the people on this call are researchers, how this shift in funding landscape and the additional challenges or hurdles in trying to write grants to do important science in global contexts. How do you think this change in funding landscape impacts what our research priorities should be for HIV and cardiometabolic comorbidities?
Yeah, this also maybe as one of the sovereignty for research. So it can directly impact. Currently, in fact, we will have the funding and the fund tailored for the interest of the funders and the like. But in the future, if we do have our own resources, we may target more of the focus to manage the specific areas. So I think at present time, the fundings are available only for implementational studies and the like. Larger studies like clinical trial, cohort and the like is not being supported by this system. So maybe the available resources are to be focused for conducting research that may have a specific impact on the outcome of the management of HIV/AIDS and the like. So that may give a solution for the current problem.
Great. I don't want to take all of the time, so if other people have questions they want to ask, please feel free to put them in the chat. Otherwise, I'll keep asking questions.
Thank
Okay,
you.
thank you.
Yeah, let's open it up for questions. Do any of you have any questions? You can post it in chat or you can unmute yourself and ask. Well, I can maybe get us started. So I have a question. I'm curious, Dr. Woldu, you talked about integrated care, right, for HIV and addressing cardiometabolic diseases. So is that happening now in Ethiopia, or is that sort of the desired state, future state?
Yeah, they are trying to integrate, especially with the strategy of the Ministry of Health,
Mm-hmm.
is designing this approach now currently. And also after the 2025 WHO guideline that supports this agenda, they are trying to integrate. But the problem is when you are integrating these services, both non-communicable
Mm-hmm.
disease and with HIV, we need to have the proper compositions of health professionals that can manage and address the problem. Those issues are still not addressed well, but they are trying to address the monitoring and the likes are available currently. We can, because I also worked on the ART clinics, they
Mm-hmm.
are monitoring those parameters, but only monitoring without addressing the problem is not a solution. So
Right.
that we see that there is some gaps on the addressing the problems, but the monitoring and the like, maybe after the recent uh, problems on funding cuts,
Mm-hmm.
maybe an issue of monitoring also may be an issue that may not be addressed. And otherwise, they are trying to address the monitoring, especially they are continuously monitoring the hypertensions and also weighing the body's weight and the like, also measuring the central obesity and the like are routinely done, especially for patients every 3 months or 6 months they do that things in recent time.
Okay, and are people living with HIV sort of are they being taken care of within the primary healthcare system, or is it still sort of siloed, separate HIV care and treatment centers?
Yeah, this thing is also uh, now it's not functional. They are trying to not discriminate the patient with HIV with separate clinics and the like. Until now, we do have a separate clinics, ART clinics, but in
Hmm.
the near futures, they want us to integrate as any type of chronic disease.
Okay.
So that's not yet done, but in the near future, that will happen soon, I think.
Okay, great. And I have one more question. I saw that you mentioned about tobacco cessation. I'm actually working on a study which is in Kenya now, which is on sort of doing tobacco cessation amongst people living with HIV. And there was a huge demand for that study. And I'm curious, are providers trained to actually, do sort of just ask people if they are smoking or, using other forms of tobacco? Is that a routine thing that's happening in the clinics in Ethiopia or not really?
Yeah, okay. Yeah, I think that rehabilitation for individuals who have this smoking, the smoking cessation is a separate activity. Usually, we do have rehabilitation centers, both
Hmm.
for this abuse, drug abuse, and also smoking and the like. They are being treated separately. So they usually advised to visit those areas, or they will be the physicians will communicate with the rehabilitation center. The patient will go there and he will be managed there. But on the ART clinic setups, only counseling and also the risk associated with smoking and the like will be uh, given for the patient. And the other thing is considering smoking. In fact, in Ethiopia, there are no uh, many smokers compared to European countries. Like I've seen that. For that's on that aspect, we do have very few individuals who are smokers.
Hmm.
I think in my study, I have seen maybe not more than 4% in the like of the population
Okay,
in IRT are smokers.
great. Thank you. I'll stop there, please. If others have questions, please unmute yourself. We have 6 more minutes left.
Okay.
Well, I guess while we're waiting to see if anyone else posts, I'm curious about whether GLP-1 receptor agonists, semaglutide, tirzepatide, and others are starting to be used for obesity or for cardiometabolic disease in Ethiopia.
Uh, Usually, currently we are not properly addressing weight reducing with medications. Usually we are targeting lifestyle modifications as a like. But sometimes we better use metformin for the
Mhm.
management of weight reductions and semaglutide and the like. Those medications relatively not available and costly for the patient. So usually the physicians recommend weight reductions with lifestyle modifications and the like. And they also are considering metformin as the drug for treating weight reductions.
Okay, I see Dr. Frankie has joined. Sorry, I work with Dr. Frankie. Any
Okay.
questions? Anyone? Dr. Frankie or anyone else? Actually, we were the tobacco cessation study that I just mentioned. Dr. Frankie is the site PI for the study in Kenya. So
Okay. Are there many smokers in Kenya?
not too many, but sorry, Dr. Frankie, go ahead. You can respond to that.
Yeah, so there's been reduction in the last 10 years, but yes, our prevalence is about 13% for a population of 55 million, so it's not small.
Mhm.
But among us, people living with HIV, it's double that, especially for men. So we have more smoking among men compared to women. Women is almost 1% nationally, while men is about 13%. Yeah.
Yeah, but there was a huge demand for that study. So, yeah.
Yeah.
Well, I think if there are no questions, we can end here. It's late for Dr. Woldu and others who have joined from East Africa. So I'm really grateful, Dr. Woldu, for you making the time to do this talk for us. It was very enlightening, and I hope things improve in the future with the, the country government kind of thinking of innovative financing to, to support. Their people. So I hope things get better. And Dr. Durstenfeld, thank you so much for making the time to lead the discussion section with Dr. Woldu. And yeah, so thank you and happy holidays to everybody.
It was my pleasure. Thank you very much.
Thank you for
Have a
joining.
nice time.
Yeah.
Okay, bye.